Hello guys, welcome. We'll be starting the live stream soon in some time, so please tell your friends and your colleagues to log in and stay connected, and we are just doing the sound check, and after some time we'll start the live stream. Thank you.
So when we are starting?
We are live.
I just wanted to see the slides once again.
One second. friends, welcome to the live stream today. And today we'll be discussing about ECG. And ECG, as you know, is a very important topic, and all of us should know about ECG. And especially people in the medicine department, people working in medicine, and also all the MBBS students, they have to know about ECG. And we'll discuss in detail about what ECG is. So we'll be starting in 5 minutes. Please bear with us while we test the connection.
Voice is audible.
हाँ. Hello friends, so we'll start the class today, and as I told you before, today we'll be discussing about electrocardiography. ECG is electrocardiography, and just so that we don't have something like last time, Sankavi just introduce the topic so that the audience can know that the sound is okay and I can get the feedback from people. So guys, okay.
Today we are going to discuss about ECG.
Okay, so guys, is my voice audible? Please write in the comments. And also, is Sankavi's voice audible? It should not be like last time and half of the lecture we couldn't hear. So I have made the changes which made the sound okay in the last time. Sankavi didi ka voice अच्छा है, ठीक है? Okay. So Eric says that Sankavi didi's voice is also okay. He is also part of the viewers, so he keeps on giving feedback. He's sitting right by my side behind the laptop. ठीक है Sankavi, we will start. So next slide. So it's a very blurred slide, but it's a very important slide. And the second line, it says God, Guru, and the Seeker. All of us, they are all in us all. You know, all three. So when we are ready, the Guru will appear. I'm not your Guru. I'm just a guide, and the teacher is inside all of you, and that's the beauty of it. So we don't have to learn from anybody. When we are ready, God will create circumstances that wisdom has to come to you. Okay, I am also a student, you are also a student, and you will say so many things in the comments box, and you will answer so many things which I might not be thinking also, and that will teach me So I am also a student, you are also a student, and God, Guru, and the seeker, we are all one, and it's all inside us. So okay, so I've dedicated this topic to us all. The seeker knew. Next. Bolo.
Electrocardiography. ECG is the study of data produced by an electrocardiogram in order to objectively infer the electrical process going in the heart.
Yeah. Next. So there is nothing to learn in the ECG. So like she said, ki electrocardiography is the study of the electrical activity of the heart, and it comes on a piece of paper or on the screen of a monitor, and that is what electrocardiogram is. And you can denote it with the ECG or EKG. Both words are okay, and in Germany they would use EKG. Otherwise in Western countries they would use ECG, electrocardiogram. And ECG is like maths, you don't have to learn the findings of different diseases and different blocks by heart. If you know the vectors, this is what my focus will be in this lecture and the subsequent lectures, that we should know the basic. If you know ABCD, you can write any word. If you know 0 to 9 numericals, you can work out any complicated equation on earth, so if you know the formula. So our fundas have to be right, and you don't have to by heart the findings, like what is the criteria for left ventricular hypertrophy or acute myocardial infarction. If we know why, what is happening, again, like I always say, when, why, what, where, how, and keep on asking these questions. The student in you should ask the guru in you, and like that, and we will find the answers. And it's a very simple topic, and I could never understand ECG, and after MBBS only, in fact, I learnt the whole of ECG. And I read Shamroth, Leo Shamroth and Goldman, and I could never understand. And then I read Hampton, ECG Made Easy, and that thing just broke the ice. And then after that, Shamroth was just fun. It was like a action novel, and it was so easy. Goldman also I could understand. So the beginning has to be crisp and clear. Okay, so I recommend that all of you should get this thing. Just a sec. Yeah. So Eric, मेरा video आ रहा है? Is my video visible? I forgot to switch it on. Eric, video आ रहा है? Webcam. Okay. So what I was saying is, like, I could not understand the ECG, but once I went through Hampton, ECG Made Easy, I could understand every book, Shamroth and Goldman and Marriott. And what I am teaching is just in nutshell is sum total of everything, how I understand and how I interpret ECG, and it is going to be fun. Next.
Who was Enthoven? Enthoven also described the electrocardiographic features of number of cardiovascular disorder. In 1924, he was awarded the Nobel Prize in Medicine for his discovery.
Yes. So Einthoven, like, he discovered a lot of findings, ECG findings in various diseases, and he got a Nobel Prize. Next slide. And his contribution in the world of ECG is the most important. Like I'll be talking about this circle again and again in the lectures, and this is what ECG is about. And you cannot bypass this circle. And also you must have noted in my bedside clinics, when I teach the students, I tell them to mentally plot all the ECG leads on this circle. Okay, and after at least 100 ECGs you should interpret using this circle in front of you. Keep a paper, draw it again and again, draw the different leads on this again and again, until you have mastered, till you can visualize the circle in your mind. So it should be like, while you're reading the ECG like this, your brain automatically maps all the leads at different degrees and all the disorders at different points on the circle. Okay, so first 100 ECGs you have to interpret keeping this circle in mind, and then you'll be a master of ECG. So in this circle, what you are seeing is all the leads, they are plotted. Okay, So like you know, there are different leads. There is lead 1, lead 2, lead 3. These are the standard limb leads. Then there are augmented limb leads. So they will be denoted by A, AVR, AVL, AVF. Okay, augmented limb leads. And then you have anterior chest leads V1 to V6. We'll be discussing about these in detail in today's lecture. And but just to break the ice, I thought I'll discuss this here also. Now this triangle, what it says is, like, these are the different leads. You know, every lead has a positive pole and a negative pole, and you have to plot the different leads properly, connect the different leads properly. So lead one is out here. The positive pole is at on the left arm and negative on the right arm, and lead 2 negative out here and positive at lower limb, left leg area. Then lead 3 positive and negative. Okay, and then you invert the picture. So then what you get is, next slide. So this is what I have drawn. It is the same diagram, and this is the best diagram I could draw, and it will describe everything. So you would plot different leads at different places. Okay, so this circle you have to remember at least for 100 ECGs, and yeah, we'll come to the details of this in later slides. Continue.
Assessment history. Patient with MI describes a heaviness, squeezing,
we had discussed this in the
choking,
last lecture. We can bypass this. So this is just the signs and symptoms of patient who is having acute MI.
MI.
So we'll just forward it. We had it. So what all things can you use ECG for? What all things can you diagnose in the ECG? So this is very important, because if you know what you can use ECG for, then it is very useful. And in fact, in every condition you will be doing ECG, and sometimes you will wonder why ECG has been ordered. And if you come to think of it, there are so many things you can diagnose. You can check the heart rate of the person, you can check the rhythm, you can read the axis, you can diagnose coronary artery disease, you can predict when the patient is going to have MI, or has he had MI, when did he have MI. You can diagnose some heart diseases, heart valve problem, some myocardial diseases, and cardiomyopathy and other things. Dilation of the various chambers, like you know, there are 4 chambers in the heart: left atrium, right atrium, left ventricle, right ventricle, and ECG can tell you which chamber is dilated. All 4 chambers dilated, like in dilated cardiomyopathy, or just left atrium is dilated, or just right atrium is dilated, or both the atria are dilated, or you are having something like or is there fluid around the pericardium, in the pericardium, is it pericardial effusion. So it is just as sensitive, almost as sensitive as an echocardiogram, or better than chest x-ray to diagnose cardiac problems. So it's a very important modality. And then certain drugs, many of the drugs, they will cause some ECG changes. Okay, you give potassium IV to the patient and you will see ECG changes. You give digoxin, you give any cardioactive drug, and that will cause changes in the electrocardiogram. And sometimes you are giving digoxin and patient will have a digitalis effect, and if you give too much of it, he will develop digitalis toxicity, and you can see the signs of digitalis toxicity in the ECG. So it is that good, and without doing the digitalis levels, you can sort of predict, okay, this is what is happening to this patient. Patient was on digoxin, he started having nausea, vomiting, and all those things, and you are wondering what is causing nausea, vomiting. Is it just aspirin which you gave, or is it the dose of digoxin and you didn't give potassium to this patient, and which is causing digitalis toxicity? So always remember, again, take home message, if you are giving digoxin, you have to closely monitor the potassium levels, and in fact you should give just 2 teaspoons of syrup KCl or something like that, or tell patient to have 1 banana or 1 orange which are rich in potassium, and that will take care of hypokalemia if the patient has. Okay, and it will not push the patient into hyperkalemia until and unless the patient has CKD or something like that. Then you can diagnose COPD. In COPD, what you will see? In COPD, you will see what will happen in COPD. Can anybody tell me what ECG changes can you see in chronic obstructive pulmonary airway disease?
Tall P wave.
Tall P wave, very good. So that's the answer. And normal voltage of P wave, I will come to details of all these waves in later slides. It is 2.5 millivolts, okay. And if it is more than that, we call it P pulmonale. And you will see you can see P pulmonale in severe bad COPD and P mitral. P mitral, you will see if there is mitral stenosis and left heart and there is left atrial dilatation. But in COPD, you will see cor pulmonale. Very good, Sankavi. And any other condition you can see other than COPD, P pulmonale? Anybody in the audience? Just think what COPD does and any other condition which can act like COPD and can cause P pulmonale, right ventricular hypertrophy. See, I just spelled out, I shouldn't have told it. So right ventricular hypertrophy, so you can see that also. That is because of, now think of all the flow chart from where the blood is going. Anybody help me out? हाँ सानकवी, आप बताओगे?
Tricuspid stenosis.
Tricuspid stenosis, and yeah, that can cause P pulmonale, but usually that will cause more of JVP issues and congestive cardiac failure type of thing, pooling of blood in the venous circulation. And more important than that, like I said, COPD, diseases which simulate COPD. Okay, so any chronic lung disease, interstitial lung disease and bad COPDs and post tubercular destroyed lung, we say post TBC sequelae. So these conditions will simulate COPD. In fact, they will just cause COPD type of picture in the lung, and it will cause a lot of fibrosis. So the blood that has to go into a very spongy lung, it's going into a fibrosed lung, which is offering so much of resistance to the lung from the right ventricle. So what is happening is the pulmonary artery hypertension starts. It will cause back pressure changes, and the right ventricle will hypertrophy, and you can see these changes in ECG. So ECG is very sensitive, and it will pick up right ventricular hypertrophy, and it will help you in diagnosis. Okay, so in COPD you can diagnose COPD, and so Amatra Paul says lung fibrosis, very good. Pulmonary artery hypertension, Ankit and Dileshwar says pulmonary hypertension, very good. So you guys are thinking properly. Okay, so we have to think of how the blood is coming to the heart from right ventricle, where it is going into the lungs, and from lungs where is it coming through what, into the left atrium, into the left ventricle, from left ventricle where is it going. Okay, so that's the thing, and you have to visualize this pathway and you will not make mistakes. So supposing you are getting confused why while right ventricle with hypertrophy, you think like there is a pulmonary embolus sitting in the pulmonary artery and the right ventricle is trying to pump blood across the pulmonary embolus. So it will hypertrophy, it will dilate, it will cause back pressure changes in the right atrium. So like that. So just keep on playing with your thoughts, and then rheumatic heart disease. You can diagnose rheumatic heart disease and in infective endocarditis. As such, infective endocarditis you can diagnose through blood tests and on echo also. But what will infective endocarditis do to the heart that you can diagnose on ECG? Anybody? In the previous ECGs, in the previous lectures, I had told you that main difference between rheumatic heart disease and infective endocarditis is. So anybody can tell me what is the main difference between rheumatic RSD and infective endocarditis based on the lung on the lesions in the valves? Tandra, CR, is Tandra here? Anybody? You have to make mistakes if you want to learn. Okay, so don't be afraid to make mistakes. So people are still answering the previous question. I think because of the delay in the comments, I'm just reading ILD and pulmonary fibrosis. So Ankit says there is vegetation in infective endocarditis. Vegetation can be there in rheumatic heart disease also. in rheumatic heart disease also. So in rheumatic heart disease mainly there will be a stenotic lesion, okay, and in infective endocarditis will affect a diseased valve. Okay, there is, let us say person has mitral stenosis or tricuspid stenosis, or there are many valves which has stenosis, so it will attack the valves which are destroyed, and it can attack the other normal valves also, but the chances are it will affect the diseased valve. Like in the jungle you see on Discovery, and there are so many deers running, one deer is injured, the lion will just target that deer, he will let every other deer pass by him, he will not even move, but when that deer comes, the injured one, it will attack. So infective endocarditis also does like that. So Ranjana Singh says fenestration, that you will see in SLE, limb and sac endocarditis, okay. But basically the question was rheumatic heart disease and infective endocarditis. So infective endocarditis will cause regurgitant lesions. अभी सानकावी आप बता सकते हो how regurgitant lesion will present, what it will do to the heart? There is MR, there is AR. Anybody in the audience? What will happen to the ventricles? What will happen to the atrium in MR, AR? So somebody please say something in the comments. Sankavi, say something. If there is infective endocarditis of the mitral valve, ठीक है, MR हो गया, mitral regurgitation. So what is it doing? So when the mitral valve is closed, okay, the blood doesn't go back into the left atrium, but in MR the blood is going back. And then what happens is when the diastole starts, double volume of blood is coming into the left ventricle, okay. So two things are happening at this time. The left atrium is dilating, one because of stenosis, then other because of stenosis and regurgitation, okay. The left atrium is dilating, then more than needed blood is coming into the left ventricle will dilate. And how will left ventricle handle that excess of blood? You imagine you are anybody is going in the gym and working out, we have weak biceps, and you are lifting let us say 20 kilos weight. So what will happen? The muscle will hypertrophy, we will exercise every day, and MR won't just suddenly happen in 2 seconds, it will occur over days, okay. So slowly the more amount of blood is coming into the left ventricle, so the LV is like as if the LV is in the gym, you know, so it will start exercising, so there will be little bit of hypertrophy also. Along with left ventricular dilatation, there is hypertrophy also, and these changes you will pick up on the ECG. So the leads which are looking towards the left ventricle, the lateral wall, they will show tall R waves, okay, and the leads which are away from the lateral and the left ventricle, they will show deep S wave. We'll come to these things in detail later on, okay. So these are the things which you will pick up on ECG, okay. Then next slide. Okay, so then again in dengue fever also you can get AV blocks, and so see ECG is so important in cardiac diseases, in respiratory diseases, in infectious diseases, in dengue fever, other viral fevers, okay. So we have to learn to think out of the box and think, can ECG be important in this patient? Can it help? Even in poisoning patients you have to do ECG. There are so many poisonings you can pick up, opium poisoning and sulfose poisoning, aluminum phosphide poisoning, and organophosphorus poisonings. Based on the heart rate you can detect which type of drug the patient has abused, you know. And if the patient has taken Fortwin, he will have marked tachycardia. If he has taken morphine, he will have bradycardia, and if he has organophosphorus poisoning, he will again have bradycardia, okay, because cholinergic crisis will ensue. And if the patient has taken alphos which we put in wheat, and that will simulate acute myocardial infarction, you will see CPK has gone very high, and there is ECG changes which are almost ditto of acute MI, but the patient has taken sulfose, aluminum phosphide poisoning, okay. And okay, so next question is, what are the cardioactive electrolytes? Anybody can tell me in the crowd? What all electrolytes can cause changes in the ECG?
Potassium, calcium.
Potassium, calcium. Very good. One more. We give these drugs. ऐसे सोचो, during emergency, during a CPR, what all things you gave? What all drugs you gave? नहीं निकल, सोडियम नहीं है. Sodium will cause CNS changes. Okay, sodium will cause drowsiness, obstructed thinking, confusion, delirium, lethargy, coma, seizures. So this is what sodium is. And potassium will cause more of cardiac effects. It can cause paralytic ileus. It can cause paralysis of the skeletal muscles also. Okay. So that is what potassium will do. Then calcium and Pranav, yes, Pranav is right. So Pranav says magnesium, Ankit also says magnesium, Amartya, Paul also says magnesium. Okay, so they all got same marks. So I have divided that mark into for all of them. So they are all right. So potassium, calcium, magnesium, at least these three electrolytes, they will cause changes in the ECG. Okay, calcium, if there is hypocalcemia, it will cause prolongation of QT interval. And potassium changes, there are so many changes. You will see E wave, U waves, and you will see the ST changes, T wave changes, and the PR changes. Okay, we'll discuss this in detail later on. But again, see, ECG you have to do in everything. If you are giving IV fluids to a patient, you need to do an ECG, because you have to see with what electrolyte is causing what harm to the patient. What can it cause some arrhythmia? And always remember, if the heart rate goes out of 60 to 100 zone, our normal heart rate is around 60 to 100, and if you go out of that zone, any kind of bradycardia can start any kind of bradyarrhythmia or tachyarrhythmia. Similarly, if you go above 100 roughly, okay, with exercise heart rate can go very high, it can go to 180 or even more than that. That is a different thing. But if you are not exercising, your heart rate is very high, and then you will have tachycardia, which can cause tachyarrhythmia, and it can cause bradyarrhythmia also. It can cause blocks also. This is what a normal AV block, AV node will do. You get lot of firings from the SA node or from the atrium. The AV will block half of this impulses. It will not let the ventricle beat so fast, otherwise we will die. So it will cause blocks. It will put 2:1 block, 3:1 block. This also we'll discuss later on. So we have to learn to think out of the box. ऐसे नहीं कि नहीं ECG का क्या ज़रूरत है and you start scolding your junior. Okay, no, that's not it. If you don't know why the ECG was done, you should go back and read up. Okay, next. Okay, so I will, this is a very lengthy slide, but I will just tell the gist of it. Now, supposing a patient comes to you with acute gastroenteritis, okay, and the patient goes into shock, and he has nausea, vomiting, diarrhea, and the patient goes into shock. So ECG, doing the ECG is very important even in this patient. You don't have to just attribute that hypotensive shock to acute gastroenteritis. Many a times there will be viral etiology which is causing gastroenteritis. In that case, that same virus can affect the myocardium also. It can cause myocarditis. So in that patient, maybe the patient is in shock not because of the fluid loss from the gut and the vomitus, but he is in shock because of the myocarditis, and you will see definite changes of myocarditis in the ECG. So see, again it is important, and a person who is having vomiting and diarrhea, he will lose so much of electrolytes, and those changes you can pick up in ECG. So again, see all these changes, why ECG is so important. So next slide. Okay, now we are done with the introduction, and now we come to the proper class. So how to take an ECG, and what do you attach and where do you attach? Next slide. Okay, so first thing is we have to do an ECG. When we were medical students, we had to do ECGs also, and we would take the same machine, that old machine we would carry, and we would connect to the patient, and we would ourselves do the ECG, and it was a very learning experience, and we learned so much about doing ECGs, how to titrate and calibrate the machine and check the values, so it was very nice. So this is how you take the ECG. So there are different leads, anterior, so leads you will attach, okay. So anterior chest lead, this is the anterior chest lead. So there are different colors. Okay, so always remember the colors: violet, indigo, blue, green, yellow, orange, red. So it's like that. And but nowadays they are not following the color scheme, but there is a color pattern to all the leads, and it is always good that you have the machine which carries the color according to the VibGeo. Okay, so lead V1 is placed in the fourth intercostal space, right to the sternum edge. Lead 2, fourth intercostal space, left to the sternum. Okay, then lead V3 is between V2 and V4. Okay, and V4 is in the fifth intercostal space, mid clavicular line. V5, fifth intercostal space, anterior axillary line, and V6, mid axillary line, same intercostal space, fifth intercostal space. And it is always good to take V3R and V4R. When I say V3R and V4R, we take this extra leads on the right side, V3R, V4R, V5R, V6R also you can take if there is right ventricular infarction, because to detect right ventricular infarction, right ventricular changes, you will not see proper changes in these 6 anterior chest leads. So then you have to do V3R, V4R also. And similarly for posterior wall MI, sometimes we take extra leads, V6, then you attach the same lead to V7, V8, V9 posteriorly. Okay, so like that. So there are different variations, different ways to take the ECG, and there are limb leads. So there are colors. Okay, so if you hold that thing like that, and there are different leads hanging. Okay, so red for right arm. So right arm, that lead goes red for right arm. R for R for red. Okay, right. So red. So right arm. Green for left leg. So green electrode will go to a left leg. So in the central there is a neutral wire. Okay, so these two wires, so these are for the left side, let us say this is for the right side. So if one of these leads has gone to the right arm, the other goes automatically to the right leg. So in emergency, especially when you're in casualty, and let us say you're in a very peripheral center, and the staff who was on duty is sick, and some patient comes with chest pain, so you have to act very fast. So you can't be reading which lead is written, where it is written. So just hang it like this: right side, left side, green for left leg, red for right arm, and you are done. The leads are placed. Okay, now you might think like how you will tie. Okay, I will ask you where you will tie the leads if the patient has both the legs are amputated, or even let's say both the arms are also amputated, or there is an IV line, or there is a lot of edema, there is cellulitis. You can't connect the lead there. So how can you take where you will attach the leads? Anybody in the crowd? Anybody? Please write in the comments, Sankavi. So you can see out here, you can place the leads electrodes over the right arm. Right arm you can place over the right shoulder, left shoulder, and on the hips, on the pelvic bone area. Okay, there you can put the electrodes for the lower limbs. So you will get the same rhythm, and like it's attached to the right leg near the ankle. Okay, so this is about the placement of the leads. So this is the first step. You have to know how to take an ECG. Okay, then what's a pacemaker? Who's the pacemaker? Okay, so normally pacemakers, they are very fast, and this is a picture of a pacemaker. This is about marathon. Similarly, we have pacemakers in the heart. There is a SA node, which is the fastest firing pacemaker, and he will take over, he will proceed, he will dominate. Then there is small pacemakers in the atrium, and then there is a AV node, and there is a ventricular muscles which can act like pacemaker. Okay, so I put a picture of a pacemaker. So pacemaker, like they have written on this t-shirt that he is a pacer. Okay, what they do is they will help the other runners to run at the particular destined pace. Like in Nike, they made that African runner run, Kenyan runner run. So he finished the race in 2 hours and 2 minutes, 42 kilometers. So for that race, he had around 40 pacers, 40 good seasoned runners who knew like in half a second how much distance they are traveling. They are that accurate, and they don't even look at the watch. So this is the function of the pacer. Next slide. So see, now this lady, she is the runner, she is competing in the race, but these two guys are the pacers, and they are awesome runners. They might be even better runners than the actual person who is participating in the game or the Olympic. So they have a special tag and special number and different color, and they are pacers. So they will know how fast they have to make their runner run so that she can win the race. So this is pacer. Next slide. So this is a race in Maldives where I was there for some time, and it was Eric's first international 5-kilometer marathon, and these are all in red t-shirt. They are all competitors. Okay, so I was running as a pacer, plus I was also running a full marathon. See, I have started bragging about myself because it makes me feel good, and you should also feel good whenever you achieve something. Next slide. So this is about pacers. Okay, so the pacemaker of the heart is SA node. The contraction starts, the impulse originates in the SA node. Okay, next slide. So SA node is called the pacer, and whenever we say sinus rhythm, sinoatrial node, okay, sinus rhythm, if the impulse is coming from the atrium, let us say atrial fibrillation, that is not normal sinus rhythm. I have seen many times they will say, sir, rate is so much, so and so, and axis is so and so, and it's a normal sinus rhythm, but sir, the patient has atrial fibrillation. No, it is not a normal sinus rhythm. Normal sinus rhythm is when the impulse is originating in the SA node. There are special characteristics and how a SA node fired impulse looks like. We'll come to that in detail later on. So SA is the fastest firing pacemaker. So this is another take home message. SA node is the fastest firing pacemaker in the heart. Then there is AV node. Atrium also can fire and can sustain life if the SA doesn't block. If the SA doesn't work, you can get SA blocks also. There are AV blocks, and there are bundle branch blocks, and then the ventricles will take over. Like God has made our body in such a way, like life has to be sustained. So the heart is the only thing, your heart is the only thing which will never ditch you. Anybody else in the world, your best friend and your person in whom you trust, they can ditch you anytime, sometimes because of some circumstance or something, but your heart will not ditch you. It will sustain life till the end. Even the ventricles will start firing. They may go into augmented idioventricular rhythm or something, but they will still try to save you. Okay, so these are the functions of the pacemakers, and there is a chronology. SA fires at the rate of 60 to 100 beats per minute roughly. AV node will fire at around 40 to 60 beats per minute, and ventricles, if they start firing, they will fire at around 20 to 30 beats per minute. So that is why keeping the hand on the pulse of the patient is very important. You can, if you keep your hand on the pulse of the patient and you get 20 beats per minute, 30 beats per minute, it could mean few things. There are a lot of ventricular ectopics. There is a 2:1 block, 3:1 block. There is a complete heart block, something like that, something really bad, and otherwise the pulse won't be that slow. And if the pulse is very fast, you will come to know it is irregular. Then probably it is not a normal sinus rhythm. So clinically, you have to correlate the findings. Okay, what you are seeing in the ECG clinically, can you see? Because the ECGs can get mixed. Your patient might not be having atrial fibrillation, but the ECG has been accidentally put in that file. So clinically, you verify the findings. Okay, and so SA is the fastest firing pacemaker. Now supposing SA stops firing, then your AV will pick up and the rhythm will be 40 to 60 beats per minute. Okay, and in that case, if the AV node is firing, what will not be there in the complexes? Can anybody tell?
Absent P waves.
Absent P waves, very good. Okay, so the P waves won't be there, and if I change the slides, it will become very cumbersome. I will show you in that circle again. And if the AV node is firing, there will be no P waves in any of the complexes. Okay, but in AVR you can sometimes see the upright P wave, then all the inverted complexes. Okay, in AVR you should remember all the complexes are inverted normally. So P is inverted, Q pattern you will see, for a QRS complex and inverted T wave. So if there is junctional beat, you might see a upright P wave. Okay, so AVR is a very important lead, and you should not ignore it thinking that it is just everything is inverted. But if something is upright in AVR, something is wrong with the ECG, something is wrong with the patient. Okay, okay, next slide. Bolo.
AV node and bundle of phase. From the SA node, the impulse reaches both the atrium first, so that they contract and push the blood into ventricles. Then impulse reaches another set of special group of cells in atrium called AV node. There is small delay in the spread of electrical impulse.
Okay, so in this diagram you can see, I think a bigger diagram will come on the next page. So this is the SA node. Okay, I think you can see, all of you. So this is the SA node in the right atrium. Yeah, and then from here the impulse is fired. Okay, so the right atrium, left atrium, they are stimulated, they will contract. Then the impulse reaches the AV node. This is a specialized again pace cells, which are the fastest firing cells, you know. So this is the electrical conducting system, and they are very fast. They are faster than the rest of the myocardial cells. So the current travels more nicely through this pathway from atrium to ventricles, through this pathway. Okay, so the impulse reaches the AV node, then there is a bundle of phase. Okay, so from here, from this bundle of phase, the two branches will start. So left bundle branch and the right bundle branch, and after that we'll come in detail on this. Continue.
The left bundle branch further divided into left anterior fasciculae and left posterior fasciculae.
Yeah.
Beyond this, the impulse
beyond this
spread a bit slowly across the myocardium through the Purkinje fibers. The right bundle branch supplies the right ventricle.
Okay, so the left bundle branch, it will divide into left anterior fascicle, which lies superolaterally. Okay, so it will come like this and be like this. Then there is an infero-medially another branch, that is a left posterior fascicle. So this is the left ventricle, left anterior fascicle, left posterior fascicle. So left posterior fascicle, it lies infero-medially, and left anterior fascicle lies superolaterally. So this orientation is very important, guys, because lot of axis changes we'll discuss later on will depend where the electrical current has been blocked. Okay, so the axis totally changes, and yeah, continues, Sankavi.
Septal fascicle. In addition, there is another third fascicle called the septal fascicle that is found nearly in 65% of people.
Okay, so this is the diagrammatic. You people can download this, or you can take it from me, or you can yourself draw this diagram and keep it. You know, this diagram is like the complete total ECG. So the different leads are placed here. So lead 1, first I'll tell you the conducting system. So there's so much to tell in ECG, like the teacher will get confused. Okay, I'll tell this also at this point, but yes, I have to be slow. So this is the left atrium, left ventricle, right atrium. Okay, so there is SA node, it is firing, it has stimulated the atria, impulse has reached the ventricle AV node, from here into the bundle of phase. From here it is dividing into two branches. Okay, then the left bundle branch and the right bundle branch. So right bundle branch is supplying the right ventricle. So at this point you have to remember the electrical conduction in the ventricles is transmurally. So this is the ventricular wall. So this is the ventricular cavity. So the impulse will spread like this through the wall. Okay, transmurally. This is the myocardium, transmurally. But in the atrium, it spreads across the surface of the atrium. Okay, so this is a very important difference in the atrium and the ventricular conduction. And in atrium, we never say left atrial hypertrophy, we just say left atrial dilatation, because of the same reason. There is hardly any muscle in the atrium, because the atrium has to just pump blood just a few 1 or 2 centimeter below into the ventricles, but the ventricles have to pump blood into, like right ventricle has to pump blood into the lungs, so it is not very bulky. So right ventricle also has little to do, so the myocardium of the right ventricle is not very bulky, so into the lungs. LV has to pump blood into the whole of the body, into the anti-gravity muscles in the legs and into the brain also, everywhere it has to pump, so the left ventricle is bulky. Okay, so coming back to the bundle branches, so this is the left bundle branch. It divides into left anterior fascicle superolaterally, left posterior fascicle inferomedially. Okay, and then left anterior fascicle will spread like this, the impulse, and it will stimulate the lateral wall of the ventricle, left ventricle. Inferomedially, the left posterior fascicle will stimulate the ventricles like this, left ventricle like this. Okay, next. Okay, one sec, Sanke, one sec, come back. So at this point also only I will explain you where the leads are placed, because otherwise we will be wasting time on more slides. Okay, and so we draw this circle, and you draw 0 degree, 180 degree horizontally through the center of the circle. Okay, so lead 1 is placed at 0 degree. You just by heart this. Okay, there are no two ways about it. So you remember there is a positive pole of a lead and a negative pole of a lead. Okay, and current cannot travel like this. Current will travel only in one direction, from negative to positive. Okay, so whenever the current is traveling through the positive pole of these leads, it is perceived as a positive or a upright deflection. When the current is traveling away from the lead, positive pole of the lead, it is perceived as a S wave or Q wave or a negative wave. Okay, this is the main thing you have to remember. So lead 1 is at 0 degree, that is a positive pole. Lead 2 is at plus 60 degree, positive pole of lead 2. Lead AVF, I am talking about all the positive poles. AVF plus 90, lead 3 plus 120, AVL minus 30, AVR minus 150. Okay, so at minus 150 degree, this is the positive pole of AVR, it is not the negative pole of AVR. Now this hemisphere is divided into, this is the negative part of the hemisphere, this is the positive part. Okay, so 0 degree, plus 60, plus 90, plus 120, outer negative, minus 30, minus 60, minus 90, minus 60, minus 180, and you remember 120. So also it is important to remember these leads are placed at a multiple of 30 degrees. Okay, so it's all 30s, multiples of 30, 30 or multiple of 30. So lead 1 is 0 degree, 30 plus 30 60, lead 2, 60 plus 30 90, AVF, plus 30 120, lead 3, lead AVL minus 30, and AVR minus 150. So they are all at multiples of 30 degrees. Okay, now this is the positive pole of lead 1 at 0 degree, and out at 180 degrees you will have the negative pole of lead 1. Positive pole of lead 2 is at plus 60, so the negative pole will be at 90 plus 30, 120, minus 120 degree. Okay, lead 2. Lead 3 is at plus 120 degree, so the negative pole is at minus 60 degree, it has to be a straight line. Okay, AVR, positive pole is at minus 150, so you go through the center of the circle, so the negative pole of AVR is at plus 30 degree. So in nutshell, this is what the ECG is, and you have to by heart it. You draw it 10 times, 20 times, look at this diagram again and again till you start dreaming of this diagram, and then there will be no stopping you. Okay, next. Bolo.
Septal fascicle bends to the interventricular septum and can arise from common left bundle, left anterior fascicle, left posterior fascicle, or both the left anterior and left posterior fascicle.
Yes. So come to that previous slide again. That's chart. Yeah. So normally in the books it is written there is a right bundle branch and a left bundle branch, and there is nothing else. But many of the books they say there is a septal fascicle also, which can arise from the left bundle branch and supply the interventricular septum. It can arise from the left posterior fascicle, it can arise from the left anterior fascicle, and it can rise from both the fascicles out here. Okay, so this is it's a septal fascicle. Continue.
Left anterior fascicle
Now,
lies
next
posterior and
next depolarization, ये बोलो.
Depolarization of IBS. IBS depolarized is the first to depolarize from left to right.
Okay, so when we are talking about the ventricular depolarization, interventricular septum is the first part of the myocardium to depolarize, and then the right ventricle and the left ventricle depolarize. So just to think anatomically, okay, this is not the anatomical picture, but you can think like right ventricle, interventricular septum is the common wall between the left and the right ventricle, and out here is the LV. Okay, so in fact when the LV is enlarged and it hypertrophies, so it will go inferolaterally like that. The apex will beat will go down and laterally. If the right ventricle hypertrophies and enlarges, the shift is like that. Okay, horizontally the apex beat is shifted up and laterally. Okay, so interventricular septum is the first to depolarize, and the depolarization occurs from left to right. So it is very important. Can you come to the previous slide again, Sankavi, that chart? Yeah. So out here, see, that's why I call this a master chart. So this is the depolarization of the interventricular septum from left to right. So it is very important. So now what we will do is we will place leads V1, V2, V3, V4. V5 lead is at the tip of the LV apex, and V6 goes little further upwards laterally, V6. That is why in the lateral leads you will have lead 1, AVL, V5, V6. Okay, but remember V5 is at the tip, and then V6 goes little upwards and laterally. So okay, हाँ next बाद में बताऊंगा.
Small sign. It is the paradoxical raise in JVP on
we had discussed this in the last class. So these slides came in between, so I didn't delete them because I will need for another lecture. So Kussmaul sign is, you will see when the right ventricle is compromised, like in inferior wall MI. So there might be a RV infarction also. You will see Kussmaul sign. Like on deep inspiration, our neck veins, they will collapse because of the negative intrathoracic pressure. There is a negative intrathoracic pressure between the two pleurae. Okay, so it will expand the chest wall cavity. It will just suck out the lung outwards, and the lung will have a negative pressure. It will just all the blood in the neck from the cranium, and like that it will go into the right atrium. Okay, this is normal. But in Kussmaul sign, on deep inspiration, the neck veins become full, because that is not happening, because the RV is not dilating, it is not expanding, it cannot accommodate the blood. And this is Osborne wave you will see in hypothermia, and that's the J point elevation which you see, and you call it Osborne wave. And we'll discuss these aberrancies or these things later on, but these slides were just there. Next.
QRS complex. QRS complex is the subtotal of electrical activity of LV and RV. LV dominates. The endocardium depolarized slightly before outer layers.
Okay, so QRS complex is the sum total of electrical activity of the left ventricle and the right ventricle. Okay, and you must remember that right ventricle is sort of a vestigial organ when it comes to producing the ECG changes. Okay, why I say vestigial organ is because it has to pump blood just into the lungs. Okay, so electrically it is not contributing too much to the QRS formation, and like it said, QRS is a sum total of electrical activity of the RV and the LV. It's not like in lead V1, V2 you are seeing right ventricle changes, and in V5, V6 you are seeing left ventricular changes. You will see changes of left ventricle in the whole of ECG. You will see the changes of right ventricular changes because of right ventricular changes in the whole of all the leads. Okay, so but LV is bulky, it has to pump blood into the whole of the body, so there is more of myocardium in the left ventricle, and more myocardium more viable myocardium, it will cause more electrical current production, and that is perceived as a tall, very very tall R wave by the ECG machine. Okay, so it is very important that LV dominates the electrical activity of the heart in the ECG. Next.
One heartbeat consists of an atrial depolarization, which causes atrial contraction, which form P wave on ECG. Then ventricular depolarization, which causes ventricular contraction, which in turn form QRS complex on ECG. This is followed by resting pace as seen by formation of T wave.
So when the atrium contract, that is a P wave is formed, okay, because of atrial depolarization. Then now you will ask, like, T wave is ventricular repolarization, sir, where is the P wave repolarization? Actually, again, the QRS is very bulky. When the atrial repolarization is occurring, at that time the ventricles are contracting, so the QRS is very strong and it overpowers the repolarization changes in the ECG of P waves. Next. Okay, so this is a normal ECG. Okay, and what you see in this is, now if we remember that circle which I was showing again and again, now see, in AVR all the impulses are inverted. P wave is inverted and QRS is inverted, T is inverted. Now QRS is of different types. Okay, you can have RS pattern and you can have R dash pattern in RBB. Okay, and sometimes there is normally a Q wave in the left lateral leads, and then you will have a QRS pattern, and in that Q is very small. That's a normal Q. If it's a pathological Q, it will be denoted by a capital Q. Okay, and if the patient has an MI, then you will not say, sir, QRS is normal or abnormal. You will say there is a Q pattern or a QS pattern. There is no positive wave. Okay, or sometimes like in lead 2, this is R pattern. Okay, so QRS nahi bolenge, you will say R. So there is a P, there is a R, and there is a ST and a T. So there is no S wave actually. Why? Because the current has started from the SA node out here. It has fired, SA has fired, then it is going to the AV node, and still the current is going towards the positive pole of lead 2. Okay, it's going towards positive pole of lead 2. It's in a straight line. So I said, whenever the current is coming towards the positive pole of any electrode, it is perceived as a good size positive wave. So in lead 2, you will get a good P wave, good RSR. See, again I am saying QRS, good R wave, and a good T wave. And at this point, you remember T follows R. Okay, so in the mind you should always say T follows R, T follows R, because if the R wave is good, it is of good amplitude. Like this is a very good R wave. It is 5, 10, 15 small squares in height. But this is a good R wave. T is also good size. Now supposing in this wave, supposing T was small or flat or inverted, it could denote ischemia or myocardial disease or some electrolyte abnormality. Okay, so it is that important. So T follows R. If T doesn't obey this rule, something is wrong in the ECG. Supposing there is a small upright T and patient has chest pain, and look at the ECG, you say ECG to theek hai. No, ECG is not right. There is a T wave abnormality. T is flat. Okay, so you have to pick up those changes. You have to be very smart and shrewd. You should be able to pick up a slightest change in the electrodes and in the ECG changes. So impulse is going from SA to lead 2 when it has to stimulate the left ventricle. So lead 2 will have only positive complexes. Now you think AVR is there at minus 150 degree and SA has fired. From the moment SA has fired, impulse is just going away from AVR. So AVR is very sad, it is unhappy. So it will say, I will not make any positive wave, I will make inverted P, inverted QS complex, inverted T wave. That is normal for AVR. Okay, if something is abnormal in AVR, now I said in junctional beat, you might see a positive wave in AVR. Why? Because let us say AV node is out here and atrium are out here, and then what happens is AV has fired, and the ventricles also have contracted, but there is a positive wave in AVR because the wave is going from AV node towards the positive pole of AVR. Okay, it's so the P wave will be upright and rest of the impulses will travel normally through the normal conducting system for AV bundle of phase, left bundle branch, right bundle branch. Okay, so this is very important. Okay, then in lead 1 AVL, lead 3, you might see a small S wave. Okay, because it is not directly in opposition from where the SA has started firing, they are little away, so a small S wave will be formed. So just by heart it and you will be fine. There's nothing difficult about it. Okay.
Function of Purkinje system. Purkinje fibers allows the heart conduction system to create synchronized contraction of the ventricles and are therefore essential for maintaining a consistent heart rhythm.
So say again.
Purkinje fibers allow heart conduction system to create synchronized contraction of ventricles and are essential for maintaining heart rhythm.
Yes. So if you see the left ventricular contractions on the echocardiogram, it's a very nice like as if that sugarcane machine is squeezing the sugarcane, you know. So it's like this. So it's a rotatory movement and it's a very synchronous, as if all the myocardium are doing a dance. So that is because there are a lot of Purkinje fibers. There's a network of Purkinje fibers, like we light up small lights on occasions, Diwali or Christmas. So all the lights, they light up in a synchronous way and they stop blinking on a synchronous way. So like that. So similarly in the heart it is like that. All the current reaches all the myocardium in a very systematic way, such that the myocardium can contract and push the blood into the respective arteries.
Different leads, limb leads 1, 2 and 3, augmented limb leads AVR, AVL, AVF, anterior chest leads V1 to V6.
Yeah, so we have already discussed these leads and the placement of these leads. So there are standard limb leads, lead 1, 2, 3, and denoted by Roman numericals. Then augmented limb leads, small a and capital other things, capital AVR, AVL, AVF. Okay. Then anterior chest leads V1 to V6, V3 or V4 are for right ventricular changes, infarctions, V7, V8, V9 for posterior wall. Next. Right now you might be a little confused and overloaded with knowledge, but suddenly it will start making sense. You just hang on and stay in the chat and suddenly it will start making sense. Yes, it is so simple. It was never so difficult. Continue. We have discussed this. So this is how you will take V2R, V3R, V4R, V5R, V6R. Okay. So you should know this because most of the machines, they will not record right sided chest leads and you have to instruct the ECG technician or the staff who is taking the ECG. In fact, you should know how to place the electrodes and take the ECG in the right side like you take on the left side. It is same. Now one practical thing in this is, supposing there is dextrocardia, true dextrocardia. Now you know dextrocardia is of 4 types. Okay, in true dextrocardia where the left is on the right side, right is on the left side, like in situs inverters. So in that, if you want to record a normal ECG, you will take all the electrodes, you will attach all the electrodes on the right side. Okay, and that will give you a normal ECG of a person looking like of a normal ECG of who has a heart on the left side, because in this person with dextrocardia the heart is on the right side. Next.
Speed on ECG paper 25 mm per second.
Yeah.
The ECG paper is ordinarily 25 mm per second. As a result, each 1 mm is small horizontal box correspond
so you need not remember all these details, but you should know when you see the ECG, when you see the ECG paper, you read the ECG, the speed of the paper at which the ECG was taken is also written on top or on the bottom in small words, 25 millimeters per second. That is the normal speed of the ECG machine, ECG paper, at speed at which the paper is coming out of the ECG machine. But sometimes there is an option you can increase the speed and you can have 50 millimeters per second speed also, and that is in special cases. Supposing you are having a very fast paroxysmal supraventricular tachycardia or some aberrant pathway tachycardia, or some VT is happening and you cannot make out whether it's a SVT or a VT. Okay, then you increase the speed of the machine, and then the complexes that were coming like this, suddenly they will become like this. Okay, so then you will be able to see a P wave which was hidden because of the tachycardia somewhere. So it is very important, a life-saving thing for you, and you should know there are two speeds in the ECG machine, and you can use it for your advantage. 25 millimeters per second is a normal one, and you can make it 50 millimeters per second also. Next. Okay, so yeah, next. Okay, so now is the calibration. So when you have attached the leads of the ECG leads, electrodes, to the patient, then you take the ECG. So first thing which you will see in the ECG rhythm in any good ECG machine is there will be a calibration. Okay, this is the calibration, and these are the normal calibrations. Okay, now calibration is 10 small squares. It has to be in height, there has to be a horizontal plateau and vertical fall. So it has to go like this, like this, like this. If supposing the machine is showing a calibration of like this, it might form a false R wave. Okay, and your whole interpretation of the ECG will change. Supposing the machine is showing like this, it might form a Q wave or a abnormally deep S wave. Okay, and it has to be 10 small squares in height, and at this point you should remember one small square is 0.1 millivolts. So 10 small square will be 1 millivolt. One small square is 0.1 millivolt. So 10 small squares will be 1 millivolt. And in duration, one ECG paper has small squares and big squares, and there are 5 small squares in length and height in one ECG, one big square, and one small square is 0.04 seconds. So one big square will be how much? Anybody?
1 second.
Point?
1 second.
0.1 second.
0.2 second.
One small square is equal to
0.04 seconds.
0.04 seconds, and one big square will be, anybody in the crowd? Wait, Asan Kavi. Anybody in the crowd can answer? There's a lot of delay, you know. Okay, so there are 5 small squares and one big square. So 5 4 is 20. So 0.20 seconds. Pranav says 0.04. So Pranav, 0.04 into 5, 0.20 seconds. Okay. So this is very important. You have to remember, because we will be playing with the different durations. Yeah, Amrital is right. Yeah. Okay, 0.2 seconds, 0.20 seconds. So one small square. So because you will get caught, you can get an MCQ question later on. I will show you. I have asked that question also. So it's very important to remember this calibration. In fact, you can refuse to interpret the ECG if you are not given the calibration. You can say, sir, please show me the calibration, because the calibration is important. But you should also know, because the teacher will ask you why you want calibration, what is the importance of calibration. So you should be able to say all these things. Also, like in this calibration, okay, this is 5 small squares in height. Now what has happened here, out here is, let us say this patient had HOCM, hypertrophic obstructive cardiomyopathy, and the machine sensed that the width of the paper is less and the R wave amplitude is wider than it will go very high, and it will bypass, the stylus will bypass the paper. So automatically it's a computerized thing, and it will halve the calibration. When the machine has sensed that the electrical activity is bypassing the paper, so it will halve the calibration. Now say in lead V5 or V6, R wave was 20 small squares in height and the calibration is 5. So actually the R wave is 40. You have to double. So you have to calculate for a calibration of 10 small squares height. Okay. So you got it, Sankavi?
Yes, sir.
हाँ ठीक है. अगर 5 पे the R wave is 20, then you multiply into 2, 5 into 2, 10, and that 20 will become 40. Okay, so calibration is very important. Next. So this is a normal ECG rhythm, and probably anybody can tell me which lead probably this ECG is from. Is it from AVR, or is it from AVL, or is it from lead 2? If yes, why? Anybody in the crowd? Today the net is little slow, so the replies are coming after a gap of 1 minute. Anybody in the crowd? Yes, now I can see in my phone the ECG rhythm which we are seeing out here, Sankavi. So just wait. So can anybody guess from where the rhythm is? Awesome. So you people are listening and you are also understanding what I am saying. So Mrinal, Yadav, Dileshwar, Nikhil, Pranav. So a lot of people are saying lead 2. Very good. So you people are right, because there is a very good P wave, there is a very tall R wave, and there is a good T wave. Probably it is from lead 2. Okay, but I also feel this is from lead 2, but this patient could be having slight axis deviation, and that is there is a small S wave also. If you had said it is, sir, it is from lead 3, that would also have been fine, because there is a small S. In lead 2 there is no S wave by default. Okay, so this ECG paper, this picture is showing you the different durations which we have already discussed. So one small square 0.04 seconds, and one large square is 0.20 seconds. Okay, and from tip of the R wave to the tip of the R wave, next R wave, that is the RR interval. Okay, so there are different complexes, different intervals, and different durations which you have to know. So I had messaged all of you in the WhatsApp group to learn the different complexes and the durations. Okay, so there is a P wave, there is a QRS wave, there is a T wave, there is a PR interval, there is ST segment, there is a QT interval. Okay, and all these intervals are very important, all these durations are very important, and we'll slowly start discussing in detail about these leads. S. Lokanwani, good evening Lokanwani, but you are very late. So anyway, welcome. So okay, so what I tell my students in the rounds and in the lectures is always you have to, when you are given an ECG to interpret, don't just look for MI, start looking for MI or something, you know, like, sir, there is a Q wave in AVL or something like that. No, that's wrong. And don't start the ECG reading from V6. From lead 1 you have to try, start reading. Look at the calibration, lead 1, lead 2, lead 3, AVR, AVL, AVF, V1 to V6, and if you have taken V3R, V4R after that. Okay, and in modern machines you will see the different leads like this, and you will see a long lead 2 also as a strip in the second row. That is very important. So long lead 2 is needed when you are determining the type of arrhythmia, whether it is a complete heart block, type 2 AV block, and or type 1 AV block, or complete heart block, or some complicated rhythm with lot of ectopics or junction escape beats and all those things. So then you need a long lead 2. Again, why lead 2? Because all the complexes are very nicely visible in lead 2. Okay, so you have to determine the rate, rhythm, axis, always rate, rhythm, axis. Okay, so if the heart rate is between 60 to 100, so a lot of things you have ruled out. So can anybody tell me what all things we have ruled out just by keeping the hand on the pulse and looking at the ECG, and we have calculated the heart rate. We'll come how to calculate the heart rate in the some slide. If the heart rate is between 60 to 100, that is the normal rhythm area of the SA firing. So if the heart rate is less than 60, maybe the person has some sort of block or conduction block. Okay, the SA is sclerodegenerated, or there is AV block or something like that. Okay, bradycardia, patient has hypothyroidism, And if there is heart rate is faster than 100, maybe this patient has some tachyarrhythmia, some VT or SVT or PSVT, or some WPW with fast ventricular response, or some atrial fibrillation with fast ventricular response. So like that. So if the heart rate is between 60 to 100, you have ruled out all these things. Okay. Rhythm. The rhythm has to be sinus. Okay, normal sinus rhythm. So always say these things. There is a normal sinus rhythm, the heart rate is so much and axis is this much, sir. I see this. Okay, so rhythm is usually normal sinus rhythm, which means the impulse is starting from the SA node. Okay, and it is firing and stimulating the atria, going into the AV node, bundle of phase, into the bundle branches and into the ventricles. So first thing to depolarize from the ventricles is the interventricular septum from left to right. That's it. In nutshell, this is the ECG. Okay. Then you see the axis. So can we have that circle again, Sankavi, somewhere? Okay. Come back. Come to that only. Then yeah. So this is lead 1, 0 to 90 is a normal axis duration. Okay. Axis finding is very interesting, and there are many ways to diagnose the axis and find the axis. Okay, so I will teach you all the 4 or 5 ways how the axis is determined. So the normal axis is quadrant is from 0 degree to plus 90 degree, which means lead 1 has to be positive and lead AVF also has to be positive. So this is the normal axis duration. Then you will have 0 to minus 90, that is left axis deviation. Okay, so if the axis is between plus 90 to 180, that is right axis deviation, or if it is from minus 90 to 180 degree, that is extreme right axis deviation. Some people call it extreme left axis deviation. So in this quadrant you will see the axis only when there is very bad severe COPD or there is a congenital heart disease. Okay, normally the axis will be between 0 to 90 degree, but from clinical point of view, axis up to minus 30 is considered normal, and the axis up to 120 degrees is considered normal. So this is in short about the axis, and you have to see the degree of axis deviation. Now for example, you see a COPD patient. Okay, his right ventricle is hypertrophied because of back pressure changes, and he has right axis deviation. He is coming to your OPD regularly, you are seeing him, you see his ECG every time, there is axis deviation of 120 degree. But then he comes to you with chest pain, and the axis deviation has taken, and it has gone from plus 120 degree to plus 150 degrees. Okay, so don't say ki no, it is okay, this axis deviation was before also. It is a significant change. This patient's axis has further worsened because he might have had a pulmonary embolism. Okay, so the axis has deviated more, and this patient's RV is dilating, RA is dilating, and it has gone into fibrillation. So like that. So you have to think, always be inquisitive. Why has the axis shifted? This patient ECG was showing axis of 120. Why suddenly it has become 150? Okay, one of the reasons is sometimes the electrodes are not placed properly. So you check the electrodes, take the ECG again. Okay, so rate, don't answer. So how you will calculate the heart rate in a patient with atrial fibrillation? So I have given this chance to the CR, Dr. Tandra. Please reply in the comments, Tandra. Saurav, you are next. You can ask and phone. Sherin, you are after that. The speed is very slow because it is buffering. So Sandy, you can tell me.
So in atrial fibrillation, the rhythm is irregularly irregular. So we'll calculate the rate by using formula number of R waves in 6 seconds into 10.
So in atrial fibrillation, the RR interval is irregular. Okay, so you can't say ki okay, before this I had to tell you how you will calculate the heart rate. Okay, so how you will calculate the heart rate? So to calculate the heart rate, there are two formulas which are very easy. Either you divide 1500 by number of small squares between two RR intervals, or you divide 300 by number of big squares between 2 error intervals. I usually go for the big square thing because it is easy to calculate, and if I want to be really accurate, then I will go for 1500 formula. So you can by heart it. So if there is one big square between 2 error intervals, so the heart rate is 300. 2 big squares 150, 3 big squares 75, 4 big square 5 big squares 60, 6 big squares 50. So it's so simple. So you can just by heart it, because my aim is when I'm looking at the ECG, the heart rate, is it between 60 to 100 or above or less than that? Okay, but in atrial fibrillation, the error interval is constantly changing. It is irregularly irregular. So we can't say, okay, from this R to R, heart rate is this. So it can't be taken as the heart rate for the whole of the ECG, whole of the patient's this thing. So in that case, you calculate the heart rate for 1 minute. So how you will calculate 1 minute in the ECG paper? Sankari? So one small square is 0.04 second, one big square is 0.2 seconds. There are 5 small squares in one big square. So how many big squares you have to add to make it 1 minute? 2 5s are 10.
300.
No, 5 big squares. 5 big squares. 5 big squares is 1 minute. 1 minute. So in 5 big squares, you calculate the number of R waves and multiply by 60.